Hey, in this video I'm going to show you how to extract some very ankylosed hidden roots that I found. You see on the x-ray here that the 407 is missing, but the roots are still there. I wanted to get them out because you see on the top x-ray here that there's a lucency around that distal root. So I was afraid there may be some inflammation there and could cause further problems down the line. So that's why I wanted to get them out. But as you see, the periodontal ligament is lacking, so they are quite difficult to get out. So I want to show you the steps here. So first you want to use your scalpel. I used a size 15 scalpel to make that incision on the dorsal rim of that bone. And I made a vertical releasing incision distally, you see here. And the reason I do that right off the bat is because I know I'm gonna have to do a lot of drilling in this case. Normally I would just use an envelope flap to get teeth out and also roots, but because I was expecting this to be a difficult case, I recommend that you simply start off by doing a vertical releasing incision. You can do it mesial or distal, it doesn't really matter. You can even do two, starting at the line angles of the adjacent teeth. I'm using a periostal elevator to create a full thickness flap, so really scrape it off of the bone. The concept here to remember when you are making a flap and releasing incision is that you have to incise into the mucosa, so into the soft flexible part, not just the gingiva. So you have to make the incision long enough. Here I lift the gums on the lingual side. This is equally important to release on the lingual side to get to these roots, but also to have a nice closure. That's the important reason why always you should release on the lingual side too. So after you give it a little bit of flush, you see here that the roots are not really visible. So how do you find roots that are hidden and you cannot really see? Well, use a round medium grit diamond burr. So this is called a football diamond burr, and just take the top bone off here. Just smooth it down a little bit until you see those roots coming into visibility here. So you can see that root, and here's the other one. So that's nice. Now we know where the roots are. So the next step we want to do is start removing the alveolar bone on the buccal aspect. So for this I'm using a root tip burr. This is a very long straight burr. This is almost 3 centimeters long, and it's quite handy because it's so thin. This is a very small dog, so it's a magnified video, so that's why everything looks big, but it's quite small actually. So using this burr to gently remove bone on the buccal aspect. Keep that flap away. You can use your periostal elevator or a wooden spatula or something else. Try not to drill too much into that periostal elevator. It happens. So you see here I'm just removing that bone on the alveolar, on the buccal side of this tooth root here. In a small breed dog like this was Pomeranian, as I recall it, then the mandibular canal, in 85% of small breed dogs, the mandibular canal is located buccal to the root. So that's an issue, right? Because if you go too deep, you will actually drill straight down into the mandibular canal. In larger breed dogs, the mandibular canal are always below the root tips. So the root tips will never reach the canal in very large breed dogs. But smaller breed dogs, the roots can be lingual to the canal, it can be buccal to the canal, it can be straight into the canal. You'll only know for sure if you do multiple x-ray views or a CBCT scan. But this is something to take into consideration when you are drilling bone in this area. You cannot go too deep. You can go maybe 70-80% max of this root's length. You cannot go all the way down because you may end up in the canal. So because these roots are so ankylosed, we do need to drill a lot. And you'll see in a minute that I'm switching instruments to another type that we will talk about. Now what I do is I make the grooves. You should always make a groove on either side of the root. What's the purpose of this groove? The groove purpose is to have a space where you can insert your elevator or luxating instrument to do the elevation. You are not supposed to push it down between the tooth and the bone. You create that space with your burr, insert the elevator, and now you have a backstop, which is the backbone. So you rest the elevator against that, and then you twist a little bit, and you see the roots moving. So this is what I mean. You insert that luxator here. Normally, this would slide right in because there's a periodontal ligament. But in this case, it's very ankylosed. So it means the periodontal ligament is no longer present in many areas of this root. That's why I switched to a piezosurgical unit. This is and you see that in a little bit, that's an instrument that will drill bone or remove bone with vibrations, with ultrasound. And the good thing about that is that if you inadvertently hit the nerve and the vessel, it will not damage it. It will just push it away. Unless it's set to a really high setting, it can actually do some damage. But in general, this is much safer than when working in this area when you have very tricky roots where you need to drill a lot. So you see, this is the piezosurgical unit. So it's looks kind of like an ultrasonic scaler tip. And they come in all different shapes. This one is a standard extraction tip for humans. So you see that I will work my way down around these root tips with this piezoelectric unit. And as the tip vibrates, it will cut the bone. And it requires a lot of water cooling because it gets quite hot. So don't touch the soft tissue. And make sure you have a lot of irrigant going on, cooling. So the reason I'm taking some time here doing this, and I want to move very slowly. This is surgery by the millimeter because I don't want to fracture a root tip and inadvertently push it into the mandibular canal. That's a true concern in this case, because when they are so ankylosed, it's very easy to inadvertently push your elevator or luxator too hard, so the roots will pop right into the mandibular canal. So I'm spending quite some time here removing bone around these roots to expose the entire root. This piezosurgical unit is very handy to use on the lingual side also, because that's a spot where it can be tricky to get your elevator or luxator in. Okay, so just working my way down and getting these roots loose. It can be nice, you see I have some suction here going on. Can be nice to have that suction so you can better see what you're doing. So here I'm working on the lingual side to get into that space, create some space for my elevator that I'll be using soon. So I feel a lot safer when using this device compared to drilling a lot in this area. But it takes more time with this one. There are other manufacturers that does other piezoelectrical units that are faster than this one. So now I go in with the elevator and I check for mobility. So you do a quarter turn, not even a quarter, maybe just an eighth turn. So you rest the elevator against the bone and the tooth, and then you do a slight turn and you see, is this tooth moving or not? If it's moving, great, you're in a good spot. You can keep that pressure for 10 seconds. Now I go to a second spot. I'm very careful here because if I twist too much, if you twist, let's say, a quarter of a round, this will break immediately. So that's why you have to have a lot of patience. You have to go in here. When it moves, wait 10 seconds. The amount of pressure you're putting on this is just what you can use with your fingers. Not like a firm twist. And this is where you need to find your inner patience. So I wasn't happy with the mobility enough, so that's why I wanted to remove a little bit more bone. So working on that lingual side will get it loose. So I'm gonna come in again with the elevator and see if now it's more mobile. Yes, it is. So I'm giving it a little bit more firm push, and you see now you get a quite nice release. So you have to imagine you're kind of removing bone all the way around the root so you can move the root sideways. You're not allowed to do any pushing with the elevator because you may push it into the canal. Only sideways movements, and this was so small I had to use a forceps. And you see that end of this root was nice and round and smooth, and we did confirm with x-ray that everything was out. So even if it looks great clinically, you always want to confirm with an x-ray if you got everything out or not. So working on that other root, now we are close to the finish line, and this is where you typically fracture roots. So you have to be extra careful, extra patient, remove a little bit more bone here. And if you don't have one of these machines, I didn't have this all the time, so just use your burr. Just be aware that make sure that you check with the x-ray how deep can you go before you enter the canal or before you risk entering the canal. So you can take a lateral x-ray and you can see how far down have I gotten so far with my burr. You can see that on the x-ray. And then you can measure, okay, I can go down 2 millimeters more before I risk getting into the canal. And then you do that, and you check with x-ray to make sure that you're not going anywhere too deep. But with this machine, you can do it more blindly because it doesn't hurt the nerve and vessel as much if you touch it compared to using a burr. Okay, so now I go in with the elevating instrument here and do the same. Squeeze it between the bone and the root. Do an eighth of a turn, just until you feel tension, and then check, is the root moving? Yeah, it is moving. Then I keep that pressure. Hold the pressure. Move to another spot. Very controlled, firm push. And now it feels loose, way loose enough that I can grab my extraction forceps and get it out. So let's check. See, it didn't. Nah. It's so small, it didn't work. I have another extraction forceps here with some beaks that are a little bit more narrow. It's always nice to have different extraction forceps for these different reasons. And you see, okay, very nice round root tip. Don't rely on that too much. Check with the x-ray, always see if everything is out on the x-ray. So next part is closure. So you want to trim any sharp pointy edges if you have any. Here I wanted to go ahead and just close and notice how this piece of gingiva has come off that tooth. It's loose, and I released that, and I released it because I wanted to be able to grab a bite with my suture and suture it to the other side. So that's okay. You have to release this part a little bit in order to get a full thickness bite. I use a monocryl 5/0 or 5/0 on a reverse cutting needle, on a P3 needle. So now you just make some interrupted sutures. You want some bites that are 3 millimeters from the edge and 3 millimeters apart approximately. So then you do a surgeon's knot. This is 2 throws, 1 above, and then 1, 2 on top of that. Again, simple interrupted, about 3 millimeters apart. A double throw, 1 on top, and then 1, 2. Of course, sometimes you get some hair into it. Try to avoid that. You see that last throw? I could have tightened that a little bit better. That's when you record in 4K, you see these details that you don't see during surgery. Okay, you want to get that hair out. So if you drape the surgical area, you'll have a better time not messing with that hair all the time. Okay, so that's pretty much it. And you also want to put a suture here in that vertical releasing incision. Soft food for 7 days. And some NSAIDs for 5 days. You're good to go. So I hope this video shows you some of the techniques I use when I have really tricky root tips, and you can do the same now for your next surgery. Don't be afraid if you don't see the roots. Now you know how to find them when they are hidden inside the bone. So yeah, see you in the next video.